welcome to COVID-19 provider update. This is the big number 30. It's hard to believe we've done 30 of these, but thank you for all your support and emails that have been encouraging us to continue to do this. Let's jump quickly into the conversation today. For those of you who didn't see the New York Times Magazine section from 2 weeks ago, there was the COVID drug wars that pitted doctor versus doctor. Very dramatic piece, some pretty interesting photographs of our physicians. But it was an interesting discussion between this issue and the tension between the passion of caring for our patients on the front lines and the desire to do research to prove whether the therapies we were trying to give our patients were actually helping them and maybe even hurting them. And interestingly, this week, the FDA came out with the elimination of the emergency approval for convalescent plasma. So it brings up this conversation for us as we hear about all of this. Why don't we go back and take a look at the evidence behind some of the therapies that we're doing? And I've asked a couple of folks today, Dr. Bruce Farber and Marsha Epstein, who are really in the heat of the battle to talk about some of the proven therapies, but really sink their teeth into the literature to show what's going on. And I think they're going to repeat some of the things I'm going to say, but as you know, I am Mr. EBM, as many of my residents call me, and I want to highlight a few things. Doing research in the middle of a pandemic, I said, is like trying to cook a fancy French meal while your kitchen is on fire. It's extremely difficult to do. And I don't want to underestimate the difficulty by doing that types of research. The second thing is, when you're in the middle of a pandemic and you're losing patient after patient, there's tremendous passion to do anything for your patient. And that, I get it. But that being said, we all fall victim to the false sense of a causal relationship between I gave drug X and Y happened. Do we really appreciate that X and Y have anything to do with each other, or is it just by chance alone that you did X and Y happened? Very, very important phenomenon. So what it calls for is discipline. And I'm not saying this is easy. We really need to be involved in randomized controlled trials with clear entry criteria and have controls. And again, the passions and the difficulty in the middle of the crisis did erupt, and I'm not judging anybody for that. But the tragedy of all of this was that in some instances, and I would say convalescent plasma, and this was not us, by the way, we participated in convalescent plasma treatment, but we want to do a randomized controlled trial. The sponsoring entity gave up on the randomized trial, and we missed the opportunity to prove whether this was helpful or harmful, and prove that to the country. We were great. We worked hard. Our researchers were amazing. We did what we could, but there were powers above us in politics that often prevented us from doing randomized controlled trials. Enough pontification on my part. I'm going to turn this over to the famous Dr. Bruce Farber, who is our chief of infectious disease. And I know he has some very strong and passionate feelings about this topic. I'm going to let Bruce take over from here.
Thank you, Tom. Several weeks ago, actually it's probably about 6 to 8 weeks ago, the newspapers were full of articles that a $12 drug that's been sitting around for 35, 40 years is the new cure for COVID. And of course, once we all read that it was dexamethasone, you know, my eyes went up. There was a pre-publication, and finally we're going to get to look at the data, and let's see how good it is. This article appeared in the New England Journal of Medicine, and I'm going to review it for you very briefly. This was a study, as you know, that came out of the UK. There was roughly 6,400 patients that underwent randomization in a 2-to-1 ratio. There were 4,321 that received the usual standard care, and 2,104 were asked to receive dexamethasone 6 milligrams orally or intravenously for 10 days. The endpoint was whether they were discharged, expired, or 28 days after randomization. So here's the results, and we can look at them a lot of different ways, but the headlines grabbed you at the following: that mortality at 28 days was significantly lower in the dexamethasone group than in the usual care group. The rate was 22.9% versus 25.7%. So now stay with me for a second on this slide, please, because we can drill down and see how good is dexamethasone. So if you look at the bottom of the slide, you look at the people who received invasive mechanical ventilation, that there was a 29.3 versus a 41.4% difference in survival. That was significant. If you look at people who only were receiving oxygen, the difference became barely significant, 23 versus 26. And if you look at the people who received no oxygen, which was about a fourth of the people randomized, you see that they did worse. Not quite statistically significant, but certainly in that direction. When you look at all patients, you see that there was a very modest improvement. So it looked like there was some value. People grabbed onto this. So this is one other way to demonstrate the data to you. If you look at all participants in box A, you see that there was a modest improvement in mortality, not dramatic. If you look at those that received mechanical ventilation, the curves splay apart a lot more. If you look at oxygen alone, they're very close. And as you can see, if you look at no oxygen, mortality was higher in the dexamethasone group. Now, what are the problems with this trial, and why should you be skeptical? First of all, it was a very short duration. It lasted only 28 days. We all know that there are a lot of people in North Shore and LIJ and other Northwell Health hospitals that lived for many, many, many weeks and ultimately passed away after they had been on ventilators for long periods of time. Those patients would have looked like successes in this trial. Secondly, there was no data at all on the side effects of steroids, infection or GI bleeds. And although I do not believe in retrospective studies as a general rule, I do believe in one that Prashant Malhotra is working on that is going to look back on all of the opportunistic and other infections that occurred in our patients. And there are hundreds and hundreds of episodes of bacteremia and fungemia. Third, there was very limited information about other therapeutic interventions. Most of the patients did not get remdesivir or IL-6 inhibitors, but it wasn't clear, and that wasn't even established. And then lastly, as I pointed out, treatment in patients not on oxygen may increase mortality. So remember, nothing, particularly steroids, is harmless, and there are always problems with steroids. And most importantly, steroid trials always need to be confirmed. There's a long history of contradictory results using steroids to treat infections, sepsis, ARDS, CAP, and other infections. Okay, other medications, let me very briefly summarize. Everybody is very familiar with the IL-6 receptor inhibitors and the one IL-1 inhibitor, anakinra. So what are the concluding thoughts to date? Well, most all of the positive results have come from retrospective studies of these agents. The prospective studies have been unimpressive, although there certainly are a couple that are still pending. My recommendation would not use these drugs with steroids and wait further data. Do not trust retrospective studies and anecdotal experience. I heard a great quote the other day. I can't say it was mine, but if you take 10 people together and you take all of their anecdotal experience, you still don't have a data set and you still have useless information. That's it. Thank you.
All right. Thank you so much, Bruce. Always interesting to hear your perspective on things. Next up, we have Dr. Marsha Epstein, who is the Associate Chief of the Division of Infectious Diseases. And Marsha was really in the front lines of caring for COVID patients and enrolling them in many different clinical trials. So Marsha, why don't you take it from here?
Thank you very much. I appreciate being here tonight and being part of the discussion. I'm going to start by just quickly going an overview of the viral life cycle because understanding this explains where some of these drugs may interfere. So SARS-CoV-2 is a single-stranded RNA envelope virus that enters the cell by binding the ACE2 receptor. There's an enzyme on the host cell that facilitates its entry. Once inside, the virion releases this RNA. The viral polyproteins are synthesized that encode for the replicase transcriptase complex. Then the virus synthesizes RNA via RNA-dependent RNA polymerase. Structural proteins are synthesized, leading to the completion of assembly and release of viral particles. So we're going to be talking briefly about chloroquine. Chloroquine affects the glycosylation of the ACE2 receptor, so interfering with binding of the virus, and also changes the pH in some of the endosomes, so also interfering with viral entry and release. Remdesivir interferes with RNA-dependent RNA polymerase. This is a brief summary of the trials. Again, it will be very brief. I feel obligated to talk about the DDRL study from France. Essentially, there's over 900 trials if you search the literature, most of them being observational. This one was brought to attention a lot by people who don't believe in that hydroxychloroquine doesn't work, because in this study there were some favorable outcomes, but when you dissect the groups, in the group that got hydroxychloroquine, they were mostly younger, they were healthier. The group that got the control groups had more diabetes, were older, more comorbidities, heart disease, etc. And it's not considered to be equal balance, and therefore the outcome isn't considered as valid. There are 5 otherwise very well done randomized control trials. Again, some in hospitalized patients, some post-exposure, and none of them prove benefit from the hydroxychloroquine. And in fact, some showed more toxicities, most showed more toxicities in that group. So in summary, the FDA has withdrawn this as emergency sort of use, and it's no longer in our armamentarium in general. I imagine we'll discuss that more during our discussion. First big report of compassion for remdesivir was compassionate use in patients with severe COVID-19. This came out in the New England Journal on April 10th, and this was very encouraging. It was basically a case series from patients from US, Europe, Canada, and Japan, and for various reasons, they could only evaluate 53, but the results were encouraging. It was mostly men, median age was 64, and the symptom duration was 12 days, and 75% completed the treatment, which was 10 days. These were sick patients. 64 patients were either mechanically ventilated or on ECMO, and only 4 were on room air. 68% improved and 15% worsened. But the clinical improvement, notably, was most pronounced in those on low flow or no oxygen, and this becomes relevant for later studies. And there were no control groups. So basically, this was just a series of patients who got compassionate use. Next came the first randomized controlled trial, which was a trial done in China, and it was published on April 29th, and it was from Lancet. They needed 453 patients to have statistical significance. And unfortunately, they only had 236. They aborted it early because the pandemic had slowed down there, but they decided to release their data. So the statistical power was reduced from 80 to 58%. They used an ordinal scale, and you'll see that a lot of these studies use ordinal scales. They changed it up per study, but in this study, I outlined was 1 was patients discharged, and 2 was in room air, and all the way up to 6, which would be death. And the clinical improvement would consider 2-point reduction on a 6-point ordinal scale. And in the study, the patients were allowed to be on other medications with potential activity against SARS-CoV-2. So some of the data, it was hard to sort through. And a post hoc analysis seemed to suggest that patients in subgroup enrolled within 10 days of symptoms, median time to improvement was better for the remdesivir group. But it wasn't an overwhelming study. There were similar results in 2 groups for death, discharge day, and time to deterioration and in viral load. But this is a study that is worth focusing on and brought a lot of attention and sort of led to the FDA emergency use. This was in the New England Journal, and it was a study from the National Institute for Allergy and Infectious Diseases, and it was over 60 sites, and it was 1-to-1 randomization of either remdesivir or placebo. And the primary outcome was the time to achieve an ordinal scale of 1, 2, or 3. I put in the bottom what the ordinal scale was. Here, 1 was not hospitalized and no limitation of activities. 2 was not hospitalized. There was some limitation of activities. You could or could not have oxygen at home. And 3, hospitalized, no oxygen. And as of April 28th, 301 patients were still enrolled and hadn't reached primary endpoint. So, but the DSMB, when doing its first analysis, was so impressed with the data, they felt it was necessary to sort of release it. And then there was a decision to sort of release it to the public. And at that point, they showed that patients receiving remdesivir had a statistical significance shorter time to recovery than those on placebo, mean 11 days versus 15 days. The benefit to recovery was driven mostly, again, by patients in ordinal scale 5, which is a low flow oxygen. And there was a hazard ratio showing a numerical decrease in mortality with remdesivir. Kaplan-Meier estimates of mortality by 14 days was 7.1% versus 11.9% placebo. Now, they couldn't test day 28 because a significant portion hadn't completed the follow-up visit. And in fact, the emergency use of remdesivir came after this by the FDA, and this study then offered people on placebo the opportunity to be put on remdesivir if they weren't doing well. At the same time, this study came out, which was actually the early part of one of the studies we conducted at Northwell, which was looking at remdesivir for 5 or 10 days in patients with severe COVID-19. There were 397 patients, 200 randomized to 5 days, and 197 to 10 days. And basically, there was no significant difference between a 5 and 10 day course. And this was important because that meant that with limited drug availability, we would now have twice amount of drug. But people were critical of the first drug from the NIAID, saying that we didn't really have a real final conclusion. So on July 10th, Gilead did a press release, and they basically took the severe trial and they compared it with 818 real-world patients. And the analysis, according to them, demonstrated that remdesivir treatment was associated with significant improved clinical recovery and a 62% reduction in the risk of mortality compared with the standard of care. 70.4% of remdesivir patients improved in day 14 compared with 59% of patients receiving standard of care, and recovery was defined as an improvement, again, in the 7-point ordinal scale, and the mortality rate for patients with remdesivir in the analysis was 7.6% at day 14 compared with 12.5% in patients not taking remdesivir. So that's basically the published data about remdesivir. There's going to be a lot of limitations because moving forward, now that remdesivir has become the standard of care, future trials are going to use remdesivir in the control group, and I'm sure we'll talk about that further. I should mention, in terms of remdesivir, there's still ongoing trials. One we'll actually be doing in North Shore is comparing patients in the outpatient setting who aren't sick enough to be hospitalized but have some risk factor for progression and at least one symptom, and we'll be giving outpatient remdesivir. There are 2 other trials that are ongoing. One is remdesivir and tocilizumab, and one is so it's remdesivir and tocilizumab, or remdesivir and placebo, and there's another trial with remdesivir and a JAK inhibitor, or remdesivir and placebo, with the thought that it looks like remdesivir works best early on, but if the patient progresses, that we could sort of affect some of these downstream complications.
All right, thank you, Marcia, for that review of the remdesivir data. It's extremely complicated. Why don't we call Ankita Sagar to join us, who is the Director of Ambulatory Quality for the Medicine Service Line and a primary care doc. And let's start talking about some of the questions. If we can go to the panel view, that would be great. All right, so good to see everybody. Thank you, Marcia, and thank you, Bruce, and welcome Ankita to join the great show here. Ankita, really quick, let me just put you on the spot here. I mean, you hear the data that Marcia just kind of went over. Bruce kind of went over some stuff. How overwhelmed are you by the amazing impact of all these drugs?
So I think it's pretty impactful, especially because not only are we trying to, in the sense that there's so much. Okay, let me redo
Wait
that.
a minute here. Did you listen to the same thing I did?
Word.
Okay,
wrong word. Let me explain.
You are my resident. You're my EBM.
I know you. I am. But I think impactful in the sense that I think when patients are reading headlines, they're not looking at data, right?
Oh,
so
well,
as
it's
a primary
impactful
care,
in the headlines. I'm saying as a
right.
doctor, do you think this
as a
is
doctor,
really a big deal?
No, I think that
that's what I'm looking for. No.
Right. what we stuck to in our initial surge was the idea that we're going to do what we know is best for the patient and we know is evidence proven until we are told otherwise. And I think that was for some physicians, that was a hard stop. For other physicians, it was very difficult to convince patients otherwise. But I think it was a conversation.
You're scooting around my question now. You're
Okay.
being very effective in saying, did you think that was really great evidence to support either one of those drugs? No, of course not. So, Marcia, I mean, I'm going to go to you. I know you did the clinical trial. You were in the front lines actually consenting patients. And if you get rid of all the silly observational trials, you end up with 2 randomized trials, if I'm not mistaken, right?
Well, there's more now because basically there was the Chinese trial. There's the one from the NIH.
Well, the Chinese trial didn't get finished, so let's forget that.
There's one from the NIH.
Let's be honest here. Come on, how many real clinical trials do you have? Like really
there's the moderate trial, which is being published in JAMA, which we participated in, which again was not overwhelming. And then there's a severe trial that I participated in, where they only released the preliminary data about 5 versus 10 days. Yes,
right.
So there's not a wealth of.
Now, I mean, this is the problem. Now it becomes standards of care, right? And now, Bruce, you looking at the dexamethasone version of all of this, and when you're around long enough, like you and I and, Marcia, we've seen the story of dexamethasone in sepsis play up and down. Every time I do morning report with the residents, I don't know which article they're going to throw at me for steroids and sepsis. Did it work or did it not work? And you said something very interesting, Bruce. You said you would not do you recommend giving dexamethasone to intubated COVID patients at this point?
Yeah, as you know, I'm very cynical of the dexamethasone data, and I'm very cynical of the length of the trial. Yes, in mechanically ventilated patients, I would do it because all of the national groups feel that there's enough power. I don't think, though, that that this story is over. And I think also that people need to realize, which we all know, that this is not a benign drug. And the first order of business.
And I think you were very obvious with that, yeah.
Do no harm. And so would I do it in a mechanically oriented ventilated patient? Yes, but that's probably it.
And Marcia, let me just ask you, would you use a randomized placebo-controlled trial of remdesivir plus placebo at this point, or do you feel that horse is out of the barn? You can't give a placebo in a remdesivir trial?
We're about to do one. We're about to do an outpatient trial.
I'm talking about it.
I think it'd be hard to do.
Yeah, I mean, that's part of the problem, right? You have weak evidence, but it's a tragic disease and people are dying. So I'm not saying I agree with you. I would give it, if I was in the hospital, give it to me. I heard Bruce say that from the very beginning. That was the only drug he wanted before there was evidence, actually.
You talk about length of stay. When we were at the peak, we had over 600 patients in the hospital. If we could cut the length of, and we were running out of beds, if we could cut the length of stay by 3 days or so, that was significant.
I agree.
You look at Tamiflu. Tamiflu, if not given early, doesn't change the world.
But I think there's a perception that remdesivir is saving lives all over the place, but it might reduce length of stay. There's no good randomized controlled trials saying it saves lives, right?
Right. So they were trying to get to. That's why the Gilead did that other press release where they're trying to show the mortality benefit, but it's not hard evidence.
Yeah. No, and again, I get it. I think it just shows how hard it is to do research in a pandemic. So,
and speaking toward what Bruce said about the ventilated patients, we were talking today about how certain hospitals said all these patients did great because they gave X, Y, or Z and they got off the ventilator. I wonder, when other people were intubating, is that when we were proning? So is a ventilated patient all equal,
Yeah, no, look, anybody's anecdotal experience is just their anecdotal experience. They think they did better. I don't buy it. Listen, it's the causal, remember I said at the very beginning, this sense of causal relationship. I did this kind of cool thing with the ventilator. I did this, they got better. I have no idea if that's the case. Maybe they were more mild cases. Maybe they didn't have as sick. I have no idea. So even their anecdotal experience, we always have to question that.
But in general, what I'm implying is that when they ventilated in that study, maybe some are very sick patients, and we don't know, because I don't know what their criteria for ventilation might still benefit, and that's we struggle with. Bruce, and if you want to.
Yeah, I think that none of these drugs are terrific, quite frankly. If there's strong signals, they're not there. Are there weak signals in selected groups? Probably, and they're there. But I don't think anybody. I mean, you gave that drug, and I remember in the beginning you said, "Wow, this patient's really turning around," and then a week later you would say, "Nah, I really don't see any effect at all from these drugs," and that's why you have to wait for the results, and the results are pretty, mediocre.
Mediocre. Okay, so why don't we move on? I have one last thing, and I think I don't know if we can, Ankita, did you hear about this? And I put you on the spot here, the MMR thing, that, they looked at some cruise ships where people had been given MMR, or Navy ships, and they found that COVID wasn't transmitted in these folks. So this is going to be interesting, and I'm going to open this up now, because I'm already thinking, how do I give out MMR to my patients and induce those T cell reactions that are going to be protective? Any thoughts on this, Ankita? I'm throwing you like really a tough one here.
So as a primary,
have you heard about it?
Yes, I have, actually.
Oh, okay, good. Well,
yes.
That's good.
And I think one of the things that goes through my mind when somebody tells me that, MMR and live vaccines are going to save so many patients from COVID-19, as promising as that sounds, I think it always comes back to, is there evidence to support it? Because MMR vaccine is a live vaccine. It does carry risks of its own. And as a clinician, I always have to think about, what are the risks and what are the benefits I'm expecting of any medication or treatment I'm recommending? So I'm not sure if there is clear evidence.
Now you and I, two primary care docs, are talking in front of two infectious disease specialists about MMR vaccines, so that's very difficult. So, all right, Bruce, any thoughts on MMR for inducing T cell immunity?
Yeah, I think it's great for inducing T cell immunity in people who need a measles vaccine. And I would give it to children.
All right.
They don't cause measles outbreaks, but as far as COVID, I wouldn't do it.
Okay. Anyway.
You know what can help? Flu shots. People should get
flu shots can help. And so listen, thank you, panel. You guys were amazing as always. Dr. Zucker, Dr. Epstein, Dr. Farber. Here's a little clip of some of the news on MMR. Could it prevent COVID? Again, we need science, we need randomized trials, we need evidence to decide whether we're going to do that or not. Next week, we're going to be talking about pediatrics and COVID. Get a new update in that. Of course, we've got schools opening, a lot happening. If you have any questions, we're going to do something new. You can send us an email with your question, or better yet, a video of yourself asking the question, and we will actually pick the best question and show it on the web video. So I was trying to think about what music. It's so tragic, I can't play the music. And I came up with Should I Treat or Should I Not, which of course is not the Clash song. The Clash song was Should I Stay or Should I Go? Great song, little throwback. My kids are like, what is that? But it's a great song by the Clash. Check it out. All right, so I think we're done here. Once again, I'd like to thank my amazing panel. I'd like to thank the team that makes this all happen, Gina Lambello, and all the folks behind the scenes that edit this and host it. And if you guys have any suggestions or questions, please email us at this email, and we'll see you all next week. Thanks.